but thank you for inviting me. Today I'm going to talk a little bit about some research that I conducted when I was based in Wales at Bangor University with a research group that spanned Bangor and Exeter, but I am now based at Northumbria University in Newcastle, as well as the Centre for Dementia Prevention in University of Edinburgh. And my talk is just going to give you a brief overview of Parkinson's disease and dementia. Dr. Larson has already in her previous presentation provided a very good overview of the cognitive and neurological aspects of the disease. So I won't go into too much detail there. But I want to emphasize a little bit more about this particular cognitive rehabilitation intervention that we are currently trying to develop for people with Parkinson's disease with mild cognitive impairment and dementia, and particularly the CORD PD pilot trial, which was the cognitive rehabilitation in dementia for Parkinson's disease trial. I'll give an example of cognitive rehabilitation, as well as talk a little bit about some of the goal-setting themes that came up in our study, which is similar, I suppose, to what Ms. Tyne spoke about in her presentation too. And then I can give some preliminary results from the pilot trial, as well as talk a little bit more about the future directions. So again, Dr. Larson covered a lot of this, so I'll just briefly go through some of the statistics and facts around Parkinson's disease and dementia. We do know that approximately 30% of people with Parkinson's disease do show dementia, and 25% experience some form of cognitive impairment. So they may not qualify for a clinical diagnosis, but they might start to notice or display some symptoms that are akin to dementia, and there seems to be some cognitive slowing and sometimes experiences, particularly in executive function and sometimes memory as well. After about 20 years, typically 80% of people with Parkinson's disease do develop dementia, and dementia is qualitatively quite similar to dementia with Lewy bodies. And this is a condition where the cognitive impairment precedes Parkinsonian symptoms. So people with dementia with Lewy bodies may experience the dementia and then later show the motor symptoms. And our study was interested in both. Again, I won't go into too much detail because Dr. Larson covered this very well. But typically when I talk about people with Parkinson's disease experiencing dementia, people assume that, oh, it's Alzheimer's disease dementia, because that's the most prevalent dementia that we're aware of. But Canada are slightly different. Parkinson's disease, we typically find that memory is affected, but as Dr. Larson said, it's not so much the encoding that is necessarily affected, or memory for episodes. It's more about a retrieval or recall problem relating possibly to executive function. And we typically find that, yes, the most predominantly affected domains of cognition or thinking and reasoning is attention, executive function, as well as visuospatial function, which Dr. Larson demonstrated and explained. So while these have all been observed in patients for quite some time, we've built a lot of evidence around these cognitive changes. We're also discovering that these can have a huge impact on the individual experiencing Parkinson's, but also their caregivers. We find that patients who do show cognitive impairment have poorer prognosis. They also show reduced compliance with palliative methods, as well as medication adherence, and are typically more likely to be admitted to a care home, whether private or government. And as well, for the caregivers, the family members, they often report higher depression, a higher burden, and reduced quality of life if their partner or their family member has Parkinson's with a cognitive component. So what can we do? There is quite a lot of work and interest in dementia in general, looking at an intervention called cognitive rehabilitation. And I want to make clear the type of cognitive rehabilitation I'm talking about. it's sort of an umbrella term as well, and can include many different strategies. But the one that I am interested for the purpose of this study focuses on social well-being, physical and psychological health. It has its roots in brain injury rehabilitation. And it's interested in what we call activities of daily living. So being able to go about your everyday, being able to make yourself a cup of tea, maybe a dinner, dress yourself, take part in social activities, and maintain independence. This is slightly different to another type of cognitive rehabilitation, often also referred to as cognitive training, whereby individual might practice certain tasks that are cognitively demanding, such as learning a language or practicing a particular memory game to try and see whether that has any corresponding effects to their everyday functioning. We take more of a focus on the functions. So you break down the function and you try and understand what is the underlying issues with them unable to complete those steps in a particular activity. So for example, with Parkinson's disease, making a cup of tea, obviously that might involve some physical components to not being able to prepare the tea, switch on the kettle, lift the kettle, put it into the mug. But is there also sometimes a cognitive element as well? Perhaps it's an aspect of not being able to strategize relating to executive dysfunction, where they can't follow the procedural steps in order to make that cup of tea. And cognitive rehabilitation is very patient-driven. Ms. Tyne really emphasized in her previous presentation of how individual this condition is to patients. We believe that interventions should therefore take that individualized approach. So the individual comes up with a goal relating to an issue that they feel that they are having trouble with. And an example from our actual study is that this was a very common one, is that patients often complained that they were forgetting to take their medication at the particular times that they wanted to take it every day. They either had to rely on their families or their paid caregivers. And for a lot of patients, this was quite obviously quite self-defeating, because they wanted to maintain some aspect of their independence. So we recruited occupational therapists to break down this particular goal. This patient, within 2 months, wanted to learn a strategy to take their medication on time every day. And the various goals are broken down into stages of descriptors, where they are observed, and this also involves a lot of conversations with the caregiver as well, of where they are currently performing on that particular goal. So in this example, he frequently forgets to take their medication. They then would break down the different descriptors of that goal being achieved from 0% to 100%, with different qualitative criteria for the patients to achieve in order to be able to say they are improving in that in the performance of that goal. So for example, sometimes they might remember to take the medication when they go out for the day. Sometimes they may remember to take the medication at home. That would be maybe a 50-50% achieve of that goal. Sometimes they will remember to take the medication both when out at home during the day, and then at 100%, where they are regularly remembering to take all of their medication that is prescribed on time. And this, again, is very much a conversation between what is realistic for the patient, involving the caregiver as well, and the therapist to decide what these descriptors will look like. For the patient, what does achieving 100% performance on that particular goal look like to them? In the interim, we would then, the occupational therapist works with the patient and the caregiver to develop some strategies. For this particular patient, they found that using some compensatory or restorative strategies, such as some simple use of items such as making use of the dotted box, having a smaller box for when they were outside of the home, because that was for the patient really frustrating that they were always forgetting the medication when they were not at home, using a whiteboard at home, and memory card prompts to act as a visual prompt to remind them to take their medication, as well as a visual prompt in their wallet or their keys if they were outside of the home, so that they had a visual prompt as well away from the home. They use strategies of engagement, so they actually practiced. The patient would go out with the caregiver, and the caregiver would have to keep quiet and not have to remind them, and see how the patient was using these compensatory and restorative activities. What also became apparent during discussions at the goal setting interviews with this particular patient is that they actually had a lot of anxiety and stress, as well as negative thoughts about their medications. They didn't feel their medications were necessarily helping. They felt that their medications was making them sleepy. So the occupational therapist also recruited a pharmacist to come and talk about the medications that they were taking and to talk through some of their concerns that they were having. So this particular goal also included a psychoeducational element to try and overcome and reduce some of the anxiety that that individual was experiencing around the management of their particular goal. And as I was saying further, the reason we want to make these personalized and individualized is that, as Ms. Turnerson was saying, it's such an individualized disease. Every patient and every caregiver will have a different frustration about their cognitive as well as their physical abilities. For our particular intervention, we try to focus more on the cognitive difficulties that they were having. It was almost impossible to focus exclusively on that. But quite often we felt that there was sometimes an area of risk, particularly because this was an intervention where an occupational therapist would be with them only for 2 months, and then later on they would have to do these activities on their own. That including something like, I want to start a dance class, or I want to start dancing alone in my home, was just a little bit too risky. And this obviously also is what caregivers as well said to us during our PPI events. But the point really for the cognitive intervention is to sort of engage in a goal setting process so that this engages the goal directed behavior. And we do know that apathy is a common complaint in Parkinson's disease. And a lot of patients experience not necessarily depression, although that sometimes can also be a component of the condition, but just feeling a little listless, not really being motivated to continue with their everyday functional activity. So we wanted to understand whether an actual goal setting intervention could help patients who are experiencing those levels of apathy. Okay. And this is what the trial looks like. So it was a pilot trial, and as a pilot trial, it's really kind of like a dress rehearsal for a much larger pilot trial, where we're going to recruit a small number of patients just to understand whether it's feasible for them to set goals and take part in the various therapies, and also to see whether there's any indications of efficacy. And as I said, this was conducted throughout Wales, particularly in North Wales. We used 13 Parkinson's clinics, and every person with Parkinson was invited to a baseline assessment where they conducted memory and other cognitive tests. We also checked and asked about their health status, their quality of life, and then we performed the goal setting and the goal rating. So as I explained before, participants would identify goals that they wanted to work on. Typically, they would have 2 to 3 goals, and then they would rate their performance based on those descriptors that they spoke through with the and decided upon with the occupational therapist on a scale of 0 to 10. 0 being they were unable to complete the task, 10 being they were able to complete the task. And both the patient as well as the caregiver, so that was usually a spouse or a family member, rated the patient on these goals. And separately, the therapist also rated the patient's goals. We conducted a randomized control trial. So patients who took part were randomly assigned to the treatment condition. And the experimental treatment condition was obviously cognitive rehabilitation. So that's the intervention of interest. But we also had a control condition called treatment as usual. So patients were just followed up as normal through their NHS or National Health Service clinic and received no intervention whatsoever. But in addition to that, we also had another condition, and that was the relaxation therapy condition. And this is a active control condition. The reason we use an active control condition is that because patients and caregivers know which intervention or which condition they are receiving, we didn't want to sort of bias any of their self-reported data that they were providing with us. If they understood that we were definitely interested in cognitive rehabilitation as improving their quality of life and their cognition, then it might be that they might, that might introduce some bias for them to say, oh yes, I am improving it, I'm getting better at it. So the point of the relaxation therapy was there to act to sort of mimic some of the interaction with the therapist, as well as to control for any expectations from the patient, as well as the caregiver in terms of the efficacy of any of these interventions. After about 2 months of working with the occupational therapist, or if they were in the control condition, just receiving no input, we would then conduct a follow-up tests where patients would perform similar memory tests, questions on their health status, their quality of life, and then importantly, rate their performance on their goals. We then left patients to their own devices and they had no therapeutic input for 6 months. And at a 6-month point, while they were just on their own, we then again tested their memory, their health status, their quality of life, and again, their goal rating, how they felt they were getting on with being able to maintain their performance on those goals. So just to summarize, the primary objective was to use this pilot trial, to examine to see whether cognitive rehabilitation was appropriate and feasible for people with Parkinson's disease dementia, as well as Lewy body disease, and explore any indications of efficacy relative to the active control condition, which was relaxation therapy, or the treatment as usual, where there was no intervention and they were just followed up by the clinical teams. We also wanted to see whether obtaining the effect sizes, and this is important for researchers to obtain when you have particularly small or pilot sample data, because it's a magnitude of effect. And the larger the effect size, the better it is, the more we smile as researchers, because that gives us some indications of whether there is efficacy in the experimental intervention that we are studying. The goals that we found, as I said before, there is a paper that I've put at the bottom if anyone is interested. Most of the type of goals related around technology, activities and pastimes, medication management, as I've said before, self-management and orientation. So a lot of our participants said that they were often confused between morning and night, or forgetting the time of day and wanting to orientate themselves to have a schedule and plan. So the occupational therapist worked a lot with them, sometimes using a simple intervention such as having a nearby for them to always be able to refer to. Losing important items was another one, always getting frustrated that they would lose their wallets and keys or books. Social interaction and communication, apathy towards social interaction was highly reported, and a lot of them felt quite anxious about social interactions, particularly those who were starting to experience some memory problems. For example, one of the participants that we worked with was forgetting the names of her family members, and she felt very self-conscious about this. So the occupational therapist designed an intervention of having photos of different family members that she came into contact on a regular basis, and she would practice matching the face with the name and carry that with her when she went to family events. So I appreciate I'm going to be showing a lot of tables, and this is just a brief background to the types of participants that we had. The majority were older adults, with an age range between 60 and 85, and varying levels of education. They were also, in terms of the UPDRS scale, which is a scale that is used clinically in the UK at least, to determine the stages, or not stages so much, but the levels of physical impairment, and as well as impairment activity in daily levels. And we found that most people were in the moderate range, and this was the same throughout all the treatment groups. We also did a background general cognitive measure. And this is called the cognitive examination. Is used a lot in UK clinics to determine the severity of cognitive impairment as well, as our participants had to qualify for either mild cognitive impairment or dementia. And then we used a neuropsychiatric inventory as well to assess depression and anxiety and hallucinations. And this is just, again, some more information about the background, but the staging, Hunan Jan staging criteria, which I won't go into explicit detail, but just some information about our participants. Okay, so did it work? Well, the primary measures, as I said before, was whether individuals who took part in the study indicated that they improved in their performance of their goals, and also whether they were satisfied with that improvement. And what we found was that our experimental intervention, cognitive rehabilitation condition, did show a strong effect size. So it did show strong indications of efficacy relative to both the control condition, which we call treatment as usual, or TAU here, as well as the relaxation therapy. We also found that satisfaction, as reported by our patients in terms of their ability to do these particular goals and maintain these particular goals, also improved in the direction of favor of the cognitive rehabilitation. And this was seen at the 2-month mark. At the follow-up 6-month mark, and remember, this was a follow-up where we left the patients to their own devices, and they had no therapeutic input, we still found that patients were reporting a high performance in their goal performance for the cognitive rehabilitation, but we didn't see any satisfaction, the improvements in satisfaction was not maintained, which is quite interesting. Perhaps they became used to being able to maintain their goals. And then we also found some interesting indications of efficacy in the secondary measures. So similar to patients, we found that carers rated patients, their partner's goals performance similarly, with indications to cognitive rehabilitation against treatment as usual and relaxation therapy. For the patients, we found that there was a reduction in depression scores in favor of cognitive rehabilitation at the 2-month mark. A measure of self-efficacy, so feelings of self-confidence in their ability, also improved in favor of cognitive rehabilitation compared to the relaxation therapy condition. And then when we looked at quality of life, particularly in the social aspect, and if you remember, I said one of the main goals that people identified was having anxiety around interacting or overcoming an anxiety of interacting in social situations. We found that cognitive rehabilitation again showed was in favor of efficacy compared to treatment as usual, as well as that relaxation therapy at the 2-month marks. And this was extended to quality of life. That is a specific measure of health. At the 6-month mark, we found that patients reported that their health status appeared to improve if they were in the cognitive rehabilitation intervention group, as well as some symptoms of Parkinson's. And interestingly, we actually saw an improvement in a delayed memory recall task at the 6-month mark for those individuals who took part in the cognitive rehabilitation group. This was not something that we were necessarily even expecting, because there are lots of questions about whether focusing on function will lead to actual cognitive benefits, but nonetheless we did demonstrate that with an impressive effect size as well. So it does appear that people with Parkinson's disease and dementia with Lewy bodies can perform goal setting for cognitive rehabilitation. It seems to be feasible to assist in that goal attainment, to improve those particular goal performance in these patient groups. But what we did find was that it is very difficult to separate the cognitive from the physical. Our study at this stage was mostly focused on those cognitive problems, so focusing on difficulty they were having for cognitive or psychosocial issues such as anxiety and depression. We have to consider for future that perhaps there may be a combination of goals that can be identified where one is cognitive, one is physical, and one perhaps is an aspect of cognitive and physical, maybe learning a new dance routine could probably be incorporated. And that would probably require some more input from other multidisciplinary input from neurology as well as physiotherapy teams. And the common themes that were identified during our sessions were anxiety, anger, frustration, as well as coming to terms with their cognitive and physical disability. And this is also important as an occupational therapist to understand that this is a progressive condition. While we had a snapshot of time really with 2 months and 6 months, we need to consider whether this cognitive rehabilitation can be applied in the long term, maybe with regular therapeutic input over years as the disease progresses. So, as I've said, we have found evidence for potential efficacy of cognitive rehabilitation to promote functional independence, so improve their well-being and that of their caregivers. But we do need to determine whether these effects can be replicated in larger cohorts. We had quite small sample sizes, but we want to see whether this can be persist in the big cohorts. So further directions that we have, and I'm very open to advice from everyone in the audience, is that we want to consolidate these therapeutic procedures. I believe Professor Hasselbach will be talking about the interaction between physical activity and cognitive ability, and this is something that we are also wanting to do, as I mentioned earlier, but perhaps looking at combined physical and cognitive therapies, not just focusing exclusively on one or the other. We want to run a fully powered randomized control trial because that is the gold standard of interventional research, the highest levels of robustness that you can achieve in research. And then we're planning currently to extend this to other NHS sites throughout the UK. This has, however, been somewhat delayed and interfered with by the current COVID pandemic. So we are also discussing ways of how perhaps some of the goal setting or interventions could be managed in a virtual or remote setting. Does a therapist absolutely need to be in the person's home? Can this be conducted through a laptop or iPad with the help perhaps of a caregiver? So these are all things that we're wanting to explore in future work. I just wanted to say thank you so much and to acknowledge all the researchers and the study team who were involved in this research, as well as, of course, the generous funding that we received from the Health and Care Research Wales, who funded this pilot trial. And I also just wanted to say thank you again to you all for inviting me. I apologize for not speaking Danish, and I hope to be able to take some questions whenever you would like. Thank you very much. And I hope that's the correct Danish. It was a Google Translate job, so okay. Hopefully it's correct.
Thank you very much, Tamlyn. Interesting presentation. I can see somebody with a question here. You get this one.
Thank you for this interesting talk. I have a couple of questions. I realize this is a pilot study, and as far as I saw, there were 9 PD patients or 1 and 2 Lewy body patients in each group with 2 control groups. So there's not very many patients. So I would say it would be very difficult to draw any conclusions on that number. Of course, you also recommend that you perform a randomized control study. Mm-hmm. So you think it's fair to draw a conclusion from such a small number?
No, as I was saying, so because of the small sample size, we were not that interested really in statistical significance. We're more interested in the indications of efficacy. We understand that we can't say anything about effectiveness, but running this pilot trial allowed us to identify if it's actually feasible for this type of intervention to be applied in Parkinson's disease. We know from Alzheimer's disease, where they have run these very large randomized controlled trials, that there are indications of effectiveness. We can't say that, but the results, if you look at the effect sizes, so the standardized mean difference between those who took part in the experimental intervention cognitive rehabilitation and those who took part in the treatment as usual or the relaxation active control condition, they are it does look promising and optimistic. But yeah. Yes, we definitely need to expand it so we can be sure.
It's the feasibility, I understand. Yeah, that's also what you said in the beginning.
Yeah.
Then I wondered, these patients were diagnosed with Parkinson's disease dementia or Lewy body dementia. In the beginning, you said you perform quality of life and memory tests. Why memory tests?
So it was not just memory tests. Sorry, I couldn't fit all of the different tests. It was also attention and visual spatial function.
Okay.
The slide that I made was just generally when I present to say groups, I use the word memory, but I probably should have emphasized it was actually mostly executive and visual spatial. But interestingly, we did find, again, very small sample size, but improvements on one of our memory tasks for those individuals at the 6-month mark who took part in cognitive rehabilitation. That might be a fluke. I wasn't expecting that, but again, that's something that was quite interesting that came out in our results.
Yeah, I'm happy with the executive tests. Thank you.
And your research covers early diagnosis of dementia and the effects of physical training in Alzheimer's disease. And you'll talk about cognitive effects of physical training in neurodegenerative diseases.
Thank you very much.
That's a hard word.
So why I'm standing here in Alzheimer's researcher talking about Parkinson's disease? Well, I know something about Alzheimer's disease, not a lot about Parkinson's disease, but I'll try to convince you that it's 2 sides of the same story. Can I get some slides on the screen? Okay. So these diseases are neurodegenerative diseases. Anyway, neurodegenerative diseases, they have aggregation of proteins, and these proteins differ from disease to disease, and the type and location of these proteins differ from disease to disease. So they are completely different or not. So there are a lot of similarities between Alzheimer's disease and, you can't find my slides? Okay. So a lot of similarities between these diseases. So there are a lot of common pathophysiological mechanisms. So they have the same types of things going on in the brain. So, oh, here we are. Thank you. Yeah. Can I change the slides? Okay. Okay, thank you very much. I'll skip that. So these common features like mitochondrial dysfunction, oxidative stress, neuroinflammation, transmitter loss, and synaptic dysfunction, things like that, they're the same for the two diseases. And we also have, in both diseases, cognitive dysfunction. We have depression, psychiatric symptoms, motor symptoms, also in Alzheimer's disease. And all these are leading to reduced quality of life. And all our treatments, as has been said earlier today, should actually target increased quality of life. And this is a complicated thing, because how do we measure that? And I think it's very difficult to measure. I've seen some significant changes in quality of life scales here, and I'm impressed because we hardly see that. And why should we focus on physical exercise? Well, there's a lot of population studies that show a clear risk of reduction for dementia in physically active people. And we think that, okay, if something reduces the risk, why not use it as a treatment for people who have symptoms? So that makes sense, perhaps. And then another important issue is that physical activity exerts an effect through two mechanisms. It makes the brain stronger, so that's an immediate effect, and it reduces the cardiovascular risk factors that are risk factors for cognitive disorders. So you will eventually see a healthier brain that will not progress to dementia, hopefully. So that's important to remember, that you can actually see these effects in with physical exercise, as well as other therapies that you already heard. So how about Alzheimer's disease? Well, we know that physical activity reduces the risk of Alzheimer's disease. That is pretty clear. I know there are some controversies about causality, but main studies show that there's a clear reduction of the risk of Alzheimer's disease. Interestingly, we see the same in Parkinson's disease. And again, this causality issue, I mean, if you are physically inactive because you are in the first part of your disease, then it's not a risk factor. It's just because it's part of the disease. But if you look at this nice study, you can see actually that people that are active very early in high school, I mean, they have a lower risk of developing Parkinson's disease later in life. So it's very difficult to see that this is actually the disease manifesting itself so early in life. So this is very convincing evidence that actually this is a risk reduction. And they see more or less the same risk reduction as we see in Alzheimer's disease. So this is very encouraging. And why exercise, and how does that modulate all these different mechanisms? And again, we have this two-sided mechanism of action. And one is the cognitive brain reserve, which is use it or lose it. So the more you exercise, the stronger your brain becomes. But there are also other mechanisms, like I told you, mitochondrial dysfunction, oxidative stress, vascular disease, neuroinflammation, and all these things. And there's a lot of evidence showing that exercise actually targets all these different mechanisms. So that's why this very interesting review, which has been updated in 2020, show that exercise is right in the middle here. So, and this means physical exercise, activity. So what about when you look at randomized controlled trials, because this is the gold standard and not population studies and the risk, but does it really matter? And this very nice and recent review shows that when you look at different diseases, and they included multiple sclerosis, you can discuss whether this is a neurodegenerative disease, but at least it's a chronic brain disorder. And when they look at a large number of studies, they see this medium effect size on quality of life, which is very interesting because this is actually what we really want to change. There are some effects on cognition, and I'll show you that later, but there are also a large effect on depressive symptoms. So some of the most important aspects of these diseases are actually affected by physical exercise. So from Alzheimer's disease, we know that we can actually use this as a treatment. And I'll just show you a study that is some years old, but it's very nice study, a meta-analysis showing that randomized controlled trials showing that exercise actually works in people with Alzheimer's disease, in people with vascular dementia. Mostly the aerobic only interventions are effective, and these studies have been done mostly in moderate to severe dementia, but it seems that there is a convincing effect in these types of patients. So we set out to do a study in earlier AD, so in mild demented patients, because we didn't have that information at that time. And we did a moderate to high intensity study in mild AD, 1 hour 3 times per week for 16 weeks, called the ADEX study. It was a Danish multi-center study, and we studied 200 patients, 100 doing this type of exercise, mostly on stationary bikes. And what we found was more or less the same. We saw effect on the simple digit modalities test, and you know all the tests now because you all seen it, and also on neuropsychiatric inventory, which is a measure of psychiatric symptoms. So very encouraging again, but a lot of secondary outcomes were negative, including the quality of health measures, including the ADL. And again, you can question, what does a change in score of 4 points mean actually to the patient? And we still don't have very good outcomes for that, I think. So we also saw a dose response effect. So the more people exercised, the higher change, the larger change we saw in the SDMT. So that was very encouraging. And we think that there could be actually a dose response effect on, at least on cognitive measures, perhaps not on psychiatric measures, but on cognitive we think there is, because we didn't see this effect on those that just exercised, let's say mid-level exercising. So what about Parkinson's disease? So there seems to be fairly substantial evidence that you can use aerobic exercise for treatment in Alzheimer's disease. How about Parkinson's disease? And I found 2 systematic reviews, and remind you, I'm not a Parkinson expert, so I had to look at systematic reviews. And what I found was that, well, 3 out of 6 studies in this review found a positive effect on cognition, and 5 out of 9 on this. And again, the most effective seems to be aerobic exercise of longer duration, which is not a surprise. So again, I would say moderate evidence for an effect on cognition with people with Parkinson's disease. Now, Annette also mentioned that we need to study what are the mechanisms, because is this symptomatic or is it disease modifying? And the reason why that's important in neurodegenerative diseases is that we have no disease modifying treatments of AD, although there has been recent approval of antibody in US for Alzheimer's disease, caused a lot of controversy. But anyway, we need to know, does it act on the specific pathology, or is there any effect on neurodegeneration? And I think that's important, because we have to prove, I think, that actually this is working on these specific mechanisms. And the reason we want modifying treatments is that even though that you could not see the difference between symptomatic and modifying treatments in the start of the treatment, because they're both working on the symptoms, you will see that modifying treatments actually delay the progression, and therefore people will stay in these better with a less cognitive dysfunction for a longer time. And this is of course important if you really want something very effective. So what do we know? Well, we have been looking for the disease modifying effects in our trial, and we looked at the specific Alzheimer's pathology, which are these proteins accumulating in the brain, and we see no effect. There's no effect on any of these proteins. The beta amyloid here, you don't see it with amyloid imaging, CSF with all the other proteins, no effect. So I don't think we can say, and I don't think anybody has proven that there is a disease modifying effect of at least on the specific pathology in AD. So another way of looking at it in Alzheimer's disease, the hippocampus is an area which is very much affected. So the episodic memory is impaired, and hippocampus is atrophied, and it has been debated whether you can see any effect. In healthy people, you can see an increase in volume if you train, if you are very active, but in Alzheimer's patients, you really can't see this a slowing of progression of this atrophy. Although some claim that you can, but actually I don't think so. The question is the right way to, do we look at the right place? As you already heard, is memory important here? And we have talked a lot about executive functions. And in our study, we didn't see any change in the hippocampal volume, but we saw actually a change in the frontal part, and that associated with the change in the SDMT, in the executive functions. So something was happening with the executive function and the frontal lobes, actually. So we think that actually it depends a lot on where to look. And maybe a lot of these studies, and I know a lot of these studies, they focus on some cognitive measures that are really not relevant here. So what about Parkinson's disease? Do we see any disease modifying effects? And I found this study because I think it's interesting. So BDNF is very crucial to the theory, the hypothesis about how physical activity influences the brain. So the muscles, they produce hormones that affect the brain-derived neurotrophic factor, which is a kind of growth factor for the brain, and therefore it's good for the brain. And actually, if you see anything, you see more in Parkinson's disease, a more positive change in brain-derived neurotrophic factor than we see in Alzheimer's disease. And there are some other studies I will not show you that actually suggest the same, that it seems somehow that you can change by diet or by supplementary things and exercise. You can, it's probably a little easier to change what's going on in the Parkinson brain than in the Alzheimer's brain. And I will not try to speculate why that could be. But anyway, it seems that there could be some disease modifying effects actually in Parkinson's disease. And if you are interested in this, I think this is a very nice review. So does exercise reduce risk and progression? And the conclusion here is that to date, trials have failed to differentiate symptomatic from disease modifying effects in Parkinson's disease. And one of the reasons is that in order to show the disease modifying effect, you have to have very long trials. You have to see this slowing of progression, and it's very difficult to do. And most trials are restricted to 5 months, where you can not distinguish between symptomatic and disease modifying effects, unless you look at these mechanisms below, the level below, and this has not been that encouraging. So some of the issues that we need to address is, of course, how to do these types of trials. And maybe some of you have done physical activity studies in patients, and we have done it in Alzheimer's disease, where the cognition is a major issue. You may have done it in Parkinson's disease, where motor problems might be more of an issue. But if you combine these two things, then you may end up with a lot of compliance problems. Of course, you have to tailor these treatments on an individual level, looking at the cognitive and motor dysfunction. So I think that's an important point to take home message, is that you really have to do this on an individualized level. Another issue is a lot of these trials, at least in Alzheimer's disease, I don't know about Parkinson, I think they're a bit more looking at the executive function in Parkinson trials, but in Alzheimer's disease has been very much focused on memory. And one thing that doesn't change with physical activity is memory. I mean, most of these studies show no effect on memory, but they show an effect on executive function in Alzheimer's disease. So that makes sense from a Parkinson perspective. So this is probably the areas where you see most effect from physical activity. That's the frontal areas where you have these functions, at least. I'm looking at, because I'm not quite sure that, but anyway, I think that the frontal lobes are involved in these functions, and this is actually where we see most of the effects. So maybe we should change our outcomes. I'll just show you an example. A few years after our trial, this trial got a lot of attention. It was negative. It was very rigorously conducted, a very nice study, but their primary outcome was the ADAS-Cog. And I don't know if you know the ADAS-Cog, but it's a mixture of, it's a global instrument tapping into all kinds of different cognitive functions. And a lot of these, like language and memory, they will not be affected by physical activity. So they didn't find an effect because they chose the wrong outcome. So I think that's very important to remember. Again, you have to choose the right outcome. So my take home messages, I think that we need to look at compliance. I know from the computerized, I don't know if that's easier to do because you could do it at home, but how should you construct a trial to do physical exercise? A lot of people, they have done it by giving a short instruction. Maybe they go to a gym, maybe they exercise for some weeks, and then they say, okay, keep on doing it at home. That won't work, it won't work. So you have to have some kind of supervision. And of course, that takes a lot of resources. So how can we do that? So that's one point. And how do we do the outcomes? Which kind of measures should we do? And I think this discussion about quality of life and activities of daily living is very important. And we really don't have really good outcomes for these, at least not in my opinion. It's very difficult to measure anything there. At least if we look at cognitive functions, then we should address these frontostriatal network functions. And that's, of course, very relevant because that's what we see affected in Parkinson's disease. I think still this disease modifying discussion, I think it's still relevant. I mean, we need to see if we can change, at least, maybe we cannot change the protein accumulations, but maybe we can change some of these downstream processes like the mitochondrial dysfunction, like the oxidative stress, the neuroinflammation, things like that. And I think that's important because that could actually alter the disease progression. And I think we have to look at that. But that requires either that we look at these functions, and that takes a lot of resources. We have to do invasive procedures, or we have to do studies of a long duration. And the question is, how do we do that? I mean, how do we design studies of more than 2 years of duration? I mean, it's extremely resourceful to do these studies, and maybe we should design them completely different. And maybe we should do this like animation. Maybe we should do some kind of at least the outcomes could be digital, so we don't have to get them in every 6 months and do a lot of measures there. Maybe we could do it digitally on the way, and maybe we should include community-based study. I mean, maybe we should do it more pragmatic. I mean, maybe we should not. A randomized controlled trial is very difficult to set up, and it takes a lot of resources. Maybe we should do some more pragmatic designs, but that's another question. I think one of the very important issues is these outcomes, and I think it has been touched upon already, and I think we'll hear more about it, that the patient involvement is very important here, because if we really want to see effects on these types of trials, then we really need to define the outcomes, communicating with the patients and the caregivers, and really finding out what's important for them, and then try to measure the changes in those outcomes. I think that's very important. I think we'll hear that in the next session. So I talked very quickly, so I made it to the coffee break. So thank you very much.
Well, thank you very much. I think we can have time for a question or two, so we won't get off that easy.
Tak, Steen, for a wonderful talk. As a really lazy person, I'd like to know how much is long duration of exercise, and how hard should I exercise?
Yeah.
So what, because you just said longer duration is better, and probably I'm thinking higher pulse, or
I think,
like what do we know about that?
I think I mean, a pragmatic way to look at it is that you have to exercise what like the recommendations are. So let's say 150 minutes per week, moderately high exercise. That would be very nice. If you do it in a clinical trial, it should be at least 3 times a week. 2 times is not enough. Maybe there are some physiotherapists here will tell me, but I think that 2 times is too little. So you have to exercise, and you have to exercise at a moderately high intensity. When I say a longer duration, is because we want to see these long-term effects on the disease, and to see if we can change the course of disease progression. So that's more the reason why to do it there. Of course, you have to keep up exercising, I guess, because this effect will wane off eventually. So you have to keep exercising, but in a trial, I think it's the reason why we want to do it of a long duration is to see this disease modifying effect.
Yeah, so the duration is the consistency over time.
Yeah.
And not the duration in one sitting.
No. Usually, I mean, the way we did it was 1 hour exercise, and they had some relaxation periods, and then they exercised with high intensity and relaxation and high intensity, and there were about, let's say, 3 times 10 minutes of very high intensity where they reached their max pulse almost. Yeah.
Have you looked at explanatory variables? Who benefits the most, or?
Pardon?
I mean explanatory variables. Who benefits the most? Can you say something about that, or what's the question here?
Not sure.
Tam?
What's?
Oh, Tam has a question.
Oh, hello. Hi, sorry.
Yeah.
I just wanted to ask, a lot of the studies, certainly in Alzheimer's disease, focus on aerobic exercise, but I do know there's also been some recent evidence suggesting that there might be some efficacy also with strength training. And I just wondered, in your review of the literature with Parkinson's disease, whether that was included in any of the systematic reviews, and if that's also not something for future to consider alongside aerobic exercise, the actual strength training elements. Obviously, there's some risks with this being a progressive muscle condition, motor system condition, but what is the landscape there with strength training in Parkinson's and cognitive development?
I think I'm not too much into the Parkinson literature, but I think in these reviews that I show you, strength training was also included there. And in Alzheimer's disease, there have been some studies suggesting that strength training actually is important too. And I think a lot of the effects that you can see on these disease mechanisms may also come from strength training. So I think, yeah, definitely. I think I don't know, but most studies have been focusing on aerobic exercise. But I think, yeah, maybe a combination. And maybe the best thing at all would be to combine all these therapies that we have heard about, but then the patient would be very, very busy.
Okay. It was a short question then, last one.
But you touched upon a very important thing about the marker of disease development. We don't have a good marker of disease development, neither for Parkinson or Alzheimer as far as now is concerned. But you mentioned BDNF, and it may increase in some cases of exercise, but I don't think you can take it for a disease marker. We treated Parkinson's disease with another neurotrophic factor in the same family years ago with GGNF, and it was infused into putamen, and there was no significant effect on Parkinson's disease.
Okay. No.
But still, if we want to prove that exercise has a disease-modifying effect, we do need a marker of modification of disease.
I think so, yes. Yeah, I agree, actually. We need to know the mechanisms behind this effect of physical exercise on symptoms. I agree completely, yeah.
Well, Chef, come.
Much more evidence from high strength training, and I guess it's because of the bradykinesia. So you overcome bradykinesia if you have strong muscles. Yeah. So this is quite another thing than actual, putting progression of disease at halt. So I guess if the cardiovascular thing of the training is much more a protective measure, I guess.
Yeah.
But again, as you said, when you have progression and you have effect on symptoms, it's very difficult to discern it in Parkinson's.
Yeah, I agree. Yeah, thank you.
Well, thank you very much.